I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm thrilled to be joined by Neil Moat, who's not only an experienced cardiac surgeon and transcatheter therapies individual, but now the CMO of Abbott Structural. Neil, you all, Abbott as a company has been a tremendous supporter of educational activities, not only for this meeting, but many. Why is that so important to Abbott's mission?
I think it's important because whilst we are able to develop new technologies, the key element of new technologies is we have to be able to train people how to use them.
Right.
And so there's no point having a fantastic piece of equipment if people can't use it or don't know how to use it. And that's a very simplistic statement.
I understand.
But we believe passionately in continuing education for established physicians.
Right.
In new technologies and in education of evolving younger physicians in training.
Right.
So both of those elements are important to us.
And you as an experienced cardiac surgeon doing a lot of TAVR procedures, certainly the relationship between scientists like yourself or others in the world and engineers within a company is incredibly important. Abbott has been a leader in that area as well as others. Tell me a little bit about your thoughts about that now being on the other side of the table.
Well, for many years, as you know, involved in the early days of TAVI, early days of MitraClip, and you develop a fairly close relationship with the company. Once you join, it's remarkable how much more depth there is in terms of engineers, innovation, really looking many years in the future. And so, as well as what people tend to see externally, which is still quite a lot, there's an awful lot of innovation and work going on behind the scenes, and some really incredibly bright engineers working on evolving the next 2 or 3 generations, say, of the MitraClip delivery system.
But their interaction, linking those smart people with clinicians is really, I think, is the way that we really do advance the field. It's good for, it's good for the physician, good for the patients, and good for the science of developing this technology.
Absolutely. I think anybody trying to develop these technologies in isolation from physicians is going to have a really tough time, because you can develop a very clever piece of equipment that nobody can use or that there's no clinical need for. So there's a really important collaboration and synergy between scientists, engineers, physicians to determine there's a clinical need, make sure the technology is being developed to answer that clinical need. I think ease of use is key. It's something that everybody can use, not just 3 people in the world who are super skilled. So
the innovations that are going on are really dramatic, I think, in the field of transcatheter therapies. Not that surgical innovations are not there. How do you view that going forward in the mitral space?
I think the mitral space and tricuspid space are much more complicated than the aortic space. I always used to teach my fellows the aortic valve's really not in the heart, it's just a valve in a tube. The mitral valve, as we all know, is a really kind of intrinsic, complicated part of the left ventricle. So that's always, to me, separated these two things. And so I think in the mitral space, we are going to need to develop multiple products. I think that there's a synergy between interventional cardiologists and surgeons in treating the mitral valve. I think they tend to have different training programs, different mindsets, and I'm a passionate believer in the heart team of surgeons and cardiologists working together. I really do believe that the patient gets the best outcome by that kind of synergy, and you're aware of the centres have got really strong heart teams. They're the people who you hear
and they're
today driving things forward.
And pushing not only pushing the development, but having excellence in outcomes, which is really important. How do you train how do we train the physicians of the future, or the cardiologists or cardiac surgeons especially, as we move into minimally invasive transcatheter therapies?
Yeah. I mean, I think we do have to evolve our training programs and training methods. I don't think you would want your interventional cardiology fellows to go and spend a year learning how to do an open aortic valve replacement. That's maybe a bit,
right.
That's too
no,
far.
I understand. Yeah.
But as this is predominantly a surgical meeting, I think we're working very hard with people like Mike Mack. David Adams is passionate about this, and there's a very interesting young group of cardiac surgeons in the US who have published on this. Mark Rousseau, Tom Green, I don't want to name them all.
Sure, you got it.
But they're very cohesive, and we're starting to work proactively with them to develop what training do established physicians need, what training do fellows need, and actually try to help them bring those skills into their individual practice.
Well, that's really good. That's really super. Just in closing, tricuspid people are finally waking up. I mean, I've been over there in the corner screaming from the echo that it's bad over there. Yeah. So you all, Abbott's been obviously a leader in transcatheter mitral therapies. You're very active in the tricuspid space as well.
Yeah, I think as we both know, having severe tricuspid regurgitation is really a pretty unpleasant thing for patients. The symptoms that they get, the bloating, the fluid retention, really is a pretty unpleasant thing to have. And I think there's pretty good data that there's a lot of it out there. And,
Absolutely.
And I think we've not seen as many patients as there are out there, because if there's not really a therapy to offer, they don't tend to get referred. I foresee a really big explosion in the number of patients with severe tricuspid regurgitation coming for consideration of intervention, and both Abbott and other companies are looking at either developing new devices. Within Abbott, we've iterated the MitraClip and the delivery system to be become a TriClip, so it's not exactly the same, different angles to facilitate implantation in the right side of the heart. So I think this will be the next big explosion in catheter-based therapies.
Well, there certainly is a need, and I think it'll be exciting. Again, Neil, thank you for all the contributions you've given to us as a cardiac surgeon, and now we thank Abbott for all the support for educational activities and pushing the science forward. Thank you very much.
Randy, thank you very much.
Good to see you as always. Good to see you, and thank you for joining us.